Welcome to the Rural Health Clinic Getting Started webinar. I'm Tom Ryan with Provider Outreach and Education, and I'll be your presenter today. Today, I'm joined by Leanne Foster. She is from my team and one of my friends. She's going to be my technical support, and she's also going to help me answering any questions and comments in the chat. She'll read those out as time permits at the end. Keep in mind, this is a Getting Started webinar, and we will answer questions accordingly. So this webinar is in response to the survey questions and the survey comments that you've asked for. We've also seen a variety of different items. Our job is to gather information so that we can build more series in this. So again, asking questions, doing all that will help. All right. Disclaimer, of course, I got to give you a few legal notices. First, I did check the information within this webinar and it is current as of today. However, CMS does change information sometimes, so you want to make sure you're aware of that. Also, some of the criteria for rural health clinics annually change, and so you want to make sure that you're aware of those criteria, the statistical areas, and other things like that, which are used for provider enrollment, and we'll talk more about those in just a few moments. Please remember that the Center for Medicare and Medicaid Services website does have all the current regulations and rules on it. They are the interpretation or the information coming from CMS that we must follow, and so must you. We will provide responses to questions that were given during the registration process. I will get as much information as I can, but I can only respond to the facts that were given and the information given. There may be times when I ask you for additional information to be added to the chat because I can't answer the question fully with what I have. So please be aware of that. Also, CMS does prohibit the recording of this presentation for profit-making purposes. We ask that you don't record, screen print, or do any other type of recording as we will do this for you. We will record it, we will post it to our YouTube channel, and it will be made publicly available. This is how we ensure that you don't use it for a profit-making purpose. We record it and we post it versus having you do that. All right, so what are we trying to do today? Well, first, we're trying to give you some general information on Rural Health Clinic or RHC's billing Medicare. This is a getting started course. This means the goal is to keep high-level information, not to get in depth with a lot of things. But another portion of this is to gather questions. The portion that is to gather questions is to determine whether or not we need to do more webinars for rural health clinics and what type of webinars you're asking for. We get a lot of survey comments. We want rural health care clinic education. I don't know what kind of education you're looking for, and I don't know what you need help with. In order for me to do the education, I have to have something more specific than we want rural health care clinic education. So keep that in mind as you're asking questions or comments. If it's not something that's going to be high level and overview, it won't fit into this getting started webinar. I will do my best to answer those, but they may be taken back and built into future education. So for this webinar as a high level overview, we will cover the Medicare criteria to be a rural health clinic. What do we have to look at under the Social Security Act to meet that criteria? Then we're going to cover the enrollment process. Now, I do have Leanne on. She's an expert in enrollment, so she may be offering help as we go through if I have other questions or items that you guys asked that I'm not sure of. I don't know all the ins and outs of enrollment, so she's got a little bit more knowledge there. Last, we're going to talk about the payment methodology, which is the all-inclusive rate and when that applies and what other services can be billed outside the all-inclusive rate, which can also be affected by some of the ways in which you enroll. So we're going to go through, again, keeping it high level. Now, the problem with it is if I try to get too down and dirty and you ask too many in-depth detailed questions, we won't make it through this comment. So please be aware that other questions, again, will be taken back and added into additional later in this series if needed. So let's get started with this coverage criteria. The criteria is the key for defining rural health clinic. These criteria were actually set in the Social Security Act, Section 1861 AA2. So when you go out to the Social Security Act, and there is a direct link on this slide, if you simply correct it, or you can Google Social Security Act, Section 1861 AA2, it'll bring it right out for you. It will go through all of this information. Based on that, then CMS puts forth the additional information, and we'll talk about that next because that's in our day-to-day guidelines. So the Social Security Act says that a facility that provides primary outpatient clinic services. So outpatient clinic, this is the goal. This is your primary purpose as a rural health clinic. This means office visits, additional outpatient type care, professional services. That's what we're looking at, outpatient standardized services. clinic services. Not outpatient hospital, not any other type of outpatient. The goal is clinic. It is a non-urbanized area. So this is done and determined by the U.S. Census Bureau, and this is some of that information that does change, and so you want to make sure that you meet that. We do have to check with the U.S. Census Bureau reports to make sure that it's still considered an urbanized area and what area that is within, so you want to make sure that you're doing the same. It has to be met as to one of the following: a designated shortage area, or certain certified within the previous 4 years. That means you're an RHC within the previous 4 years. That means the designated shortage area has been certified. Also, additional RHCs can be carried over for a period of time. We'll talk more about that. So there's a variety of factors that go into it, and when we look at all of these different pieces of information. All right, let's move on. We take this definition, so we know that it has to be outpatient clinic, we know it has to be in a non-urbanized area, and we know that it has to be basically in a designated shortage area. Let's move on from here and take it and see how that comes into play. So CMS then says, great, we've got this definition in the Social Security Act, but what else do we need to do? That's where they give us the day-to-day guidelines. Now, this is the Medicare Benefit Policy Manual, and they do have guidelines for rural health clinics specifically and federally qualified healthcare centers. Now, we're going to focus on the portion for rural healthcare clinics. The reason that CMS mixes these two together is because a lot of their information is similar. They do give you all of the general guidelines. You will see on my screenshot when they do specify. So if you look at the RHC and FQHC staffing requirements, which is section 30, they will actually tell you which is for RHC and which is for FQHC, should it not be universal. Should it not be universal. So when it's universal, then we're just going to look at overall one. This would be an example of section 20. For those of you that are not familiar with this, I did provide a link because I was asked for this, but I'm going to show you where to find it as well on the slide. So if you just simply select the chapter 13, it will open this section automatically. Takes a little bit to do that, just FYI, but this is what we're looking at here. So Medicare Benefit Policy Manual, Chapter 13. The entire thing is for RHCs and FQHCs. You're going to look for the RHC information, and that will be designated. Section 10.1 would be specific to RHCs. Well, if you scroll down, Section 10.2 would be FQHCs. So we want to make sure we're hitting up the right information. One of the specific questions I had was if I could show this without having to search for it or without having that direct link. And let me do that real quick here. So you're going to go to cms.gov. We go to Medicare. Underneath there, go to regulations and guidance. And this is where some people get confused because they're looking for where all this information is stored. It's actually regulations and guidance. And then it's in the manuals. It's in the manual. So manuals is the first one on the left side there. And once that opens, we're going to go to the left-hand side of your screen. You're going to go to Internet Only Manuals. Once Internet Only Manuals opens, you're going to scroll down and you're going to see a list of publications. Now, this is just the first 10, but we're going to look for 100-04, which is the Medicare Claims Processing Manual. We're going to look for 100-02, which is the Medicare Benefit Policy Manual, 100-02. Once you open that up, again, I told you it was chapter 13 and it is labeled RHC and FQHC. That's what we were just in. So this will look familiar to you. I'm going to leave that up, but I'm going to go back to the CMS website as well. So when we talk about the different information and the staffing requirements and what we have to look at, this is one of the areas that we do look at when we determine whether or not you'll meet the criteria to be an FQHC or an RHC. And you cannot be both. You can be one or the other, but you can't be both. All right. So what else do you have to know? Well, let's talk about the next criteria that we already mentioned, designated shortage area. What is a designated shortage area? Well, it's a geographic primary care healthcare professional shortage area. What does that mean? It's an area that's found statistically to not have enough primary care providers. So it's a shortage area and they're looking at the primary care healthcare professionals. That's one type of a shortage area. Now keep in mind, to be an RHC, you don't have to meet all of these. You don't have to meet all of these. You do have to meet one of these, okay? Population group primary care. So this is a different type, but it's a different population group primary care shortage area. So it's a different type of an area. We also have the medically underserved areas. Now, these are just population areas that don't have enough medical professionals in general. This does not including the medically underserved population group designation. Different than a shortage area, right? Different than an underserved area. A population is one set of people who are not getting enough of it, where an area is an entire geographical area that don't have enough medical service. So population versus area, and you have to meet the area but not the population. Now you could meet the population as part of the area, that's fine, but you can't just have that population alone. Then there's also the governor designated and secretary certified shortage area. A little bit different. One is a federally done one and one is a governor's, as the name states, right? But you'll notice it's still an area, it's still not that underserved population. And that's the key criteria that we're looking for. If it's just the population that's underserved, if there are services and they're not getting to those populations, that's not going to make you a rural healthcare clinic. It must be the area. Now, as we said, part of a rural healthcare clinic criteria is that it has to be for professional or standard clinic services. This means that we're going to look at who can perform the services, and they should be professional services. That's part of a clinic. Clinics primarily are serviced by professionals. So physicians would fit into this category. Also, non-physician practitioners, which are nurse practitioners, physician's assistants, certified nurse midwives, clinical psychologists, and clinical social workers. One of the questions we had is, can mental health services be performed in a rural health clinic? Clinical social workers do mental health services. That's their whole job. So yes, they can be. They must be billed with your revenue codes and your matching procedure codes in order to be considered. That's more of a billing statement, and that's just something I thought I would throw in there because the basic question was, can a mental health service be performed? And the answer is yes, they can be. Now, when we talk about these professional services, I want you to remember that this is a clinic setting. Therefore, Incident to services do apply. And Incident to are integral services. They have to be done in order for another portion. They're also part of a service or considered as a service. So we do want to make sure that the Incident to services rules do apply. So a nurse could perform part of a service for a physician as the physician begins to do that, that E&M or evaluation and management office visit. That would be fine. Those are Incident to the physician service. There are specific staffing requirements for rural health clinics though, and we do check this. They must employ an NP or a PA. That is who has to be employed. Now that's a nurse practitioner or a physician's assistant. They must have an NP, PA, or certified nurse midwife working at the clinic at least 50% of the time the clinic is operating as an RHC. So if you operate as something else, such as a lab, then no, this doesn't apply to you. Some people asked me about that in particular because they do have overnight service, but the clinic isn't open overnight. It's the lab portion where they're running tests and doing other things like that, which is a separately billable service. That would be something that lab service does not need to have one of these available at that time. So hopefully that makes sense to the person that asked that question. If not, feel free to put it back into the chat and we'll get you some more information. So an RHC practitioner, again, the physician or the non-physician practitioner must be present. At least one of these practitioners must be available to furnish care at all times the RHC is in operation. This means so you must have an NPPA or CNA 50% of the time, but someone must be available when your hours of operation exist. You can close for a lunch period of time. That's not considered your hours of operation. That was another question that was asked. Do your hours have to be consistent on a daily basis? No, they can change. It's just when you're open. A clinic that is open solely to address administrative matters or to provide shelter for inclement weather is not considered to be in operation hours during this period of time and is not subject to staffing requirements. I took this verbiage because of the inclement weather section. It was a question asked from someone and they wanted to know, they have a portion of the clinic that's open, but it's not used for the clinic after a period of time. The clinic hours shut. 2 hours later, they open as a shelter during the winter months for inclement weather when it's going to be cold, when it's going to be whatever. Does that count, and do they have to have staffing available? No, that's not what we're talking about here. Remember, an RHC is a healthcare clinic. That's what we're looking at, rural health clinic. So if you're not using it for that purpose, don't count those criteria. An NPPA or CMA must be available to furnish care at least 50% of the time. We already talked about that. The requirement can be fulfilled through any combination of those three, as long as it equals 50% of the time in total. Only the time that the NPPA or CMA spends in the RHC, or the time spent directly furnishing care in another location as an RHC practitioner, counts towards this 50% time. Another location could be a patient's home, and there's a variety of other situations like a skilled nursing facility. We'll talk about those that still count as RHC services. So you want to make sure that you're aware that if you're using that, that can count towards your time. Please note, it does not include travel time to these locations or time spent not furnishing patient care while in these locations. So you get there, you're waiting for the patient to be ready, you're moving between rooms at that facility, such as a skilled nursing facility. That time doesn't count, it's actual in-care time. The next question, someone said, is there that are covered in specific services? And absolutely, they have to be medically reasonable and necessary to start with. Medicare only covers medically reasonable and necessary services. So that's one of the things. The next item that is under the Social Security Act is the treatment of an illness or injury in a malformed body part. And so we want to make sure that you are aware of that. And then there's all other categories. So other categories, preventive care, right? These are not reasonable and necessary. As a matter of fact, they're the opposite. They're trying to prevent a medically necessary service. So there's certain things that they can do that would qualify as a service within that. And these are based on the Social Security Act. The question that was asked is, how does it flow, or what do we do with that, and how do we compensate the professional? I'm not really sure if these purple boxes on the right side are going to answer that. I hope it does. So a professional performs the service. They must be under the RHC, under the umbrella of the RHC, otherwise it doesn't count. The RHC bills Medicare. The RHC compensates the professional. Medicare compensates the RHC. The RHC includes services in the cost report. Remember, that's that annual report which sets your all-inclusive rate unless you're a very small provider, and we'll talk more about when you're a very small provider. But every RHC does the cost report, and the goal of the cost report is to balance at the end of the year. So someone did ask very specifically, okay, so what would be an example of something that is not an RHC service? A great example of this would be durable medical equipment, right? Not an RHC service, not even part of the services. So what else would be part of the service? Well, part of the services would include transition care management. So someone said, is this medically necessary? And no, that might fall under the all other care. It's definitely there. Chronic care management, advanced care planning. Here you'll see again, mental health services are part of this. Physical and occupational therapy, visiting and nurse services. Now, I will tell you that I did get a variety of questions on visiting nurse services, so much so that I decided to build another webinar next month just to cover that topic. So I'm going to try to stay in general away from that. I'll mention it a few times, but there's a webinar next month covering that. Also, telehealth originating site. This is definitely something you can do through 12/31 of 24. This is the current ruling. There's also the preventive health services. Now, these must be under the U.S. Preventive Services Task Force, USPSTF, but they must be considered a grade A or B service to be covered. That would also then make them exempt from the cost share portion for the patient, so whether that's the deductible or co-insurance. And we'll talk more about that in a little while. All right, so we know that all of that makes sense. So what is this visit? Remember, a visit must be a face-to-face, one-on-one encounter between the patient and an RHC practitioner of any kind, during which time one or more RHC services are rendered. One or more. There are separately billable services, such as durable medical equipment, that could be handed out during that time, but they do require a separate enrollment and separate billing from an RHC billing. However, effective January 1st, 2022, a mental health visit is a face-to-face encounter or an encounter using an interactive real-time audio and video telecommunication technology, or audio-only interactions in cases where the patient is incapable or does not consist with the other one. Wow, that was a lot said. So here's the basics of that. For mental health, you can use other types of encounters other than just face-to-face for a rural healthcare clinic. That's where telehealth services come in for mental health. They are done for the diagnostic, evaluation, and treatment of a mental health disorder. They could be done by a social worker or another type of professional who is state qualified to perform mental health services. Okay. Let's talk a little bit about that first one, transition care management services. These are also considered rural health visits. These services must be within the practitioner's scope of practice, and only at the required skill level of the RHC practitioner are considered rural health visits. In other words, while they can do transition care management, it must be something, one, the patient needs at that time, two, you have to be state licensed for it, and three, it has to be medically reasonable and necessary. What's going on there is what we're looking at. What is the skill level of that practitioner? A rural health visit can also be a visit between a homebound patient and an RN or LPN under certain circumstances. Now that would be considered, again, homebound patient, and it would be considered incident 2 depending on the criteria, but there's a variety of things that you have to play in with that one. We're not going to get into all of those criteria, but it is considered a valid rural health encounter. Why do we keep saying that? And it's going to be about the payment methodology that's used later on. So we'll get into that a little bit more when we get into some of that different stuff, because there is a couple of different ways a rural health clinic is paid depending on the service they're performing. So a rural health must be done in certain locations. What kind of locations would that be? I use pictures in this case. The clinic, well, that makes sense, right? You're a rural health clinic, you're a clinic, therefore you should have the medical area to do the services for a clinic visit. That makes sense. A patient's home is next. Absolutely, Medicare will cover a patient's home. That is not any different than anything else. A nursing home, we talked about this. Now, it has to be a Medicare certified nursing home and different things like that, but that's fine. At the scene of an accident, absolutely. If you are at the scene of an accident, you need to treat the patient, we will cover it. Now, that does not cover the ambulance transport. That is a separate benefit. It's not typically done in a clinic, right? Therefore, it's still going to fall under it. Now, can a rural health clinic own an ambulance? Sure they can. It's just not payable under their rate. And then we also will look at patients' hospice elections, and then where are they at for that certified hospice, which could be a residence, it could be a certified hospice facility, or a variety of others. So that's my last picture here and what I was trying to illustrate to you. So these are your payable locations. All right. That's the criteria. So as we go through those criteria, remember, we're talking about what came from that internet-only manual. I'm going to ask that if you have any questions on the criteria, put them into chat. In the meantime, I do have one. The question that was submitted that I haven't answered yet is, are drugs covered when furnished in a rural health clinic? And the answer is yes, a drug is considered a clinic service, so therefore would be covered. However, drugs furnished by rural health physicians and non-physician practitioners to Medicare patients, they have to be payable under the paid for the rural health service, which means that they're payable under the rural health payment rate. They are not separately payable, okay? So when we look at those pieces of information, that's very key that we talk about that. Can we talk, Leanne, can we take any other questions that we have?
Tom, we have one question, and it is asking if a swing bed is a payable location.
A swing bed is a payable location. It would fall under the same category as a skilled nursing facility because it's not exactly the same, and I do understand that, but it's acting as a skilled nursing facility or in place of a skilled nursing facility. So that's what makes it payable. Any other questions?
And we do not have any other questions at this time.
Okay. Next, we're going to talk about enrollment. Now, enrollment is the area where we actually talk about how to get started and what you have to do. So you have to know the criteria, but enrollment is what Medicare uses to make sure you meet every single one of the criteria. That's why there's so many different jobs and sections and areas. There's so much that goes with it that CMS has a whole separate manual for this, and it's called the Program Integrity Manual. And then they have a chapter within that for Medicare enrollment. As a matter of fact, within that chapter, they have a section for rural health clinics. And you can see that pictured here on your screen. I gave you the link in the area to find it out. So when our enrollment people are looking at this, yes, they're going to look at this section. They're going to look at the basics. Hey, did you fill out the right form? Are you doing the right things? Do you have the subparts? Do you meet all those different parts of the law? They still look at a variety of other aspects, such as the rural health designation that came from the other area and all of those different criteria. So this will give you some basic pieces about enrolling this rural health clinic and how you do that. Because remember, a rural health clinic is going to build Part B services to the fiscal intermediary shared processing systems. We want to make sure we're utilizing those special enrollment criteria. Okay. So let's move through this enrollment process because it does get a bit confusing. The first thing that came up is what are the actual ways to enroll? And with this, I did put a variety of pictures on here. The first thing in the first picture on the left side is actually PCOS. This is the Provider Enrollment Chain and Ownership System. It is an electronic system. It is a paperless system. Now I say that and then I say, except you can upload paper to it. That's because you still have to upload attachments, things we need, licensures, all that. Unfortunately, you're not going to get away from not being able to upload those. However, you can upload them versus mailing them. So that's what we're going to talk about. I will always recommend PCOS. It's the best way to enroll, the best way to make sure you have everything. A lot of people have said, or some comments were that PCOS isn't user-friendly, you don't like creating the account. I understand that there are processes and things that go in place, and I understand that everyone has their own personal opinions on those. Here's the thing. Once you can get into this account, once you can look at that, once you can get to that information, it will save you time and money. Also, keep in mind, CMS is currently developing PCOS 2.0, which should help you with some of those processes. Unfortunately, I don't know when that's set to go. There's no like set go live date. I know it's in testing. So you can imagine there's a lot of testing components. I'm going to always encourage you, use PCOS. If you don't have an account or you don't have someone linked to that, take advantage of it. Now, with a rural health clinic, the basic way that you'll enroll is the 855A. This gives you the special designation status as a rural health clinic. It is what allows you to bill for the all-inclusive rate, the AIR, and we're going to talk about the AIR in just a little while. This does not mean that, on the other hand, you would not need to bill an 855B. So this could be for something like lab services that are not part of your all-inclusive rate, the technical component of a lab. Could also be if you're doing certain types of radiology services or other types of things. Also, if your people perform outside of certain things or in different locations, you may need an 855I. In a lot of cases, you're going to need that to get them enrolled so that they can then assign the benefits to the 850 to the rural health clinic, because there's a variety of different factors that all play into this. So hopefully you get all of those different things. Why do I recommend PCOS again? I recommend PCOS because every one of those paper forms is in one electronic system. You don't have to go through and do everything. It all ties together. You can check the information. Less entering. Now, again, you do have to get a user ID. You do have to go through the setup process. I understand that. However, it does make it a bit better. Okay. So if you want to do one of the other forms, that's fine. Okay. Let's move on from just the ways to enroll. Again, keeping it really basic there. Health clinic is a rural health clinic is subject to paying the enrollment fee. Now, the enrollment fee is used for initial enrollment, revalidation, adding a practice location, or a change of ownership via the CMS 855A. Now, only when there are certain criteria, which is the buyer's not accepting assignment on the current provider agreement. In other words, that they're going to get a new assignment, they're going to get a new set of information. So a lot of times you say, well, I need to do this or I need to do that. Do I need to pay the fee? If it doesn't meet these criteria, you're not going to pay a fee with that, even though it's a rural health clinic and you are submitting it on an 855A or an 855B. For instance, what other questions we got in is they are a rural health clinic. They are using the 855B for lab services. They do outside laboratory services. So do they need to pay an enrollment fee when they got a new certification for that lab? In other words, they got a new CLIA certification, and that's not something that we're adding. You're not adding any of these criteria. I'm going to ask Leanne if she has an opinion on that. I don't believe you do, but Leanne, let's make sure with the expert.
To add a CLIA, no. The one time that you would have to add a fee, nope, I'm just making sure I wasn't double muted. Sorry, Tom. One time you might have to pay a fee is if you're increasing the number of your locations. So if you're adding that CLIA and increasing the number of locations, then the fee does apply. But again, it's because of that increase in locations, not because of the CLIA.
All right, thank you. Like I said, Leanne's my expert there. I like to ask her for the additional input just to make sure we're getting all those covered areas for you and I don't miss any of the parts of your questions. So yes, you may need to pay a fee for that, and keep in mind that does apply if you're doing an A or a B, 855A or 855B, or you're using that PCOS. Instead of doing either one of those, it's still going to work that way. Next is the documentation. Now there's some key pieces of documentation that everyone has to submit, and that's what the first slide is. The second one is what's going to make you an RHC and the RHC specific documentation. That's on the next slide. So let's talk about those key pieces that everyone has to submit. First, the electronic funds transfer agreement. If you're enrolling with Medicare for the first time or you have not done this already, which pretty much everyone has, you will need to submit your electronic funds transfer agreement on the first, or if you need to make this change. This allows for us to do a bank-to-bank transfer. This is a requirement. Medicare tries not to send checks at all anymore, bank-to-bank transfer. We will need license and certification. You heard me mention CLIA. That is one of the licenses that we need, the certifications that we need. However, there are other ones that your facility may have, so we need any of those. Education verifications for any providers, which could be, you know, your any of the nurses or anything else providing services, especially some of those home services. Your drug enforcement agency certification. The next one I want you to put optional next to, it's called adverse legal action. If you don't have any, then there's nothing you need to submit except for to say, I don't have any. If you do have some, then we need the final legal action. We need the paperwork, the discharge statement, all of that kind of stuff from the courts. You also need your internal revenue service documentation. That must match the information on the application. And it doesn't matter if you're doing an electronic application or a paper application. We have to be able to match those two together. Also, your participation agreement. Now, someone said, do I have to be a participating rural health clinic? No, you can do a claim by claim basis, but if you're going to, and it is a recommendation that you do that, but again, it's a recommendation. Now, do all of these pieces need to be sent every single time? And the answer is no. There are times when, depending on the action that you're taking with provider enrollment, you don't need to do this. And a great example of that was that electronic funds transfer. Once you have it set up, you don't need to send that in every single time you try to do anything. We don't need that. Now, if you're changing your banking information, sure, we need that. And along with the agreement, which is a CMS 588 form, 855 is provider enrollment forms, 588 is the electronic funds transfer agreement. You'll want to make sure that you also have a valid letter from the bank or canceled check or other supporting documentation to support those bank account changes. So there's some key pieces there. Let's not forget, though, that as a rural health clinic, you will need two additional key things. One, you'll need the health insurance agreement for rural health clinics. This is a CMS form 1561A, and it's just designed to help make sure that you meet all those criteria, that you have all of the agreements, that you will be doing what CMS says as a rural health clinic. There's also a verification of the clinical data. Now, this is the stuff that says I attest that I have all of this stuff on file, that I'm meeting all those requirements, that I'm identifying that I also have the proper professionals. They're there the right amount of time, 50%. Remember, for the NPPA or CNA or CNM, while they are practicing their services, that's what we're testing to. We're verifying that we meet all of those different types of things. And that's what these two agreements are. So they are things that we use to verify and make sure that you're doing the different items that you need to do. Now, keep in mind, I did link to both of those forms. Should you need an example, they are on the CMS website. Both forms are on the CMS website. All right, I'm going to move on and we're going to do some enrollment questions. Before I open for questions that you guys put into that chat, I do want to let you know that I'm going to ask just a couple of questions that we already had, then we'll come back to those. So can an RHC enroll for more than one status? And yes, they could enroll. They enroll separately for certain paid services on the CMS 1500 claim form. Now, what we're saying is, could you do something different like durable medical equipment? Sure, that's going to be a separate form. Could you do something different like lab or ambulance? Sure, that's a different type of a form because those are built differently from the UB04. So an RHC can have different statuses depending on what other services they perform, but their basic clinic statuses, their basic visit statuses, their basic home visit statuses, those are what we're looking at for the RHC payments and the RHC information. So we'll talk more about that when we get to some of the fee schedules, because that's going to drive which forms you'll want to submit. Someone asked for Kansas for a Medicare Advantage plan, do they need to use the 855A? I can't answer that when it comes to enrollment. I also can't answer that when it comes to billing or anything else about an RMA plan. We don't know that. Each MA plan is unique and different, and therefore they must answer their own questions as to their own requirements. So I don't know if they'll need the 855A. I don't know if you'd bill on a UB04. I don't have any of that information available to me. With that, Leanne, do we have any other enrollment question and answers or questions?
We do not have any enrollment questions, but we do have one that goes back to coverage.
Sure.
And they're asking about the 50%. So the question is if there is any guidance on how to calculate that requirement.
No, as far as I know, there's no guidance on the actual calculation. What they do want you to do is to look at the total number of hours, and it's going to be more of a formula, a mathematical type formula that you're going to use. They want you to look at the total number of hours you're open. So let's say you're open 8 hours a day, 5 days a week. That makes 40 hours. Excluding any of those other times that we talked about, like the one example where they gave us where it was a warming shelter. We're not going to talk about that. We're just going to talk about, hey, I'm just open for 40 hours a week. And then they say 50%, so 20%, calculate that. And you have to look at whether it's a nurse practitioner, PA, or certified nurse midwife. Are they, one, in a patient's home servicing that patient at that time, or in a facility servicing that patient at that time? Are they in the clinic working? And as long as you meet those requirements, then you're good. Keep in mind, what you're looking for is, do you meet 20 hours during that time, because that is the 40-hour requirement. Could you have other practitioners, such as a doctor, actually doing some of the services at the same time? Absolutely, but you still have to meet that 50-hour requirement. Leanne, from a provider enrollment perspective, do you have anything else to offer on that?
I do not.
Okay, I just wanted to make sure, because sometimes on provider enrollment, they'll need a log to prove certain hours and how many people were working at which times and all that. I don't know that we need that for this particular type of perspective.
They do not.
Okay, thank you. Any other questions?
That is all we have in the chat at this time.
All right, well, let's move on. Of course, the next we have, what are the pay schedules and what are we looking at? Well, first, oops. Sorry, you guys, I'm having trouble with my mouse today. Not used to that sensitive wheel on it. So the all-inclusive rate. Now, this is a set rate per visit established by Congress. It is one set rate for the entire visit. It's not something that we control. Now, there are some exceptions to this, and I'll talk about those in just a little bit. But if you want to think about it, Congress sets a rate and says, as an RHC, this is what you get per visit. That's it. So it's one all-inclusive rate. It's going to incorporate everything under the RHC. So what doesn't this incorporate? Again, I've mentioned this, durable medical equipment. Remember I said you got to do a different form because you're not going to get paid that way. Ambulance services, lab services. These do not meet the all-inclusive rate. They are separately. Also, they're separately billed. And so when you think about that, that's what you're looking at when you talk about some of the other enrollment and the other items. How are you going to get paid? Now, of course, CMS says, hey, we're going to set this. Congress said, yep, you get this amount. This is what it is. And they say, hold on, except if you're. And what's the exception? If your RHC has under 50 beds, that's what it's termed, then you can meet an exception. And instead of being under the all-inclusive rate set by Congress, you could be under a rate set by your cost report or your annual cost settlement. Cost report is what Medicare commonly calls it. Some people call it their cost settlement each year. What this does is reports a variety of services back and forth. You have to make sure everything is done correctly. If it is, it could establish a rate, but again, you have to be under a certain number of beds to meet that requirement. This again is filed annually and can adjust annually, just like the amount will adjust annually under Congress. Congress sets the amount, it's for a certain time frame. They do not have to adjust it annually. Currently, they have set an amount that will change a little bit throughout the years. I think it's set to 2028. I'm not really sure, but let me give you a source in a second that look that up at. Okay. One thing to keep in mind with your all-inclusive rates, this is a Part B service. That means the Part B annual deductible and 20% patient liability do apply. So we want to make sure you are aware of that. They do apply a little bit differently because though you're getting paid at an all-inclusive rate, they may apply under a different set of rates. So for instance, the Medicare physician fee schedule rate, and then it looks a little funky when you get your all-inclusive rate because you're like, how did this apply that way? How did you apply $125, but the all-inclusive rate was $90? That's where it's coming from. It's going to apply at a different rate more than what you would just get paid under your all-inclusive rate. So hopefully that does make sense. I'm going to tell you one of the best booklets I've seen to lay out that particular piece of information is called the Update to Rural Healthcare Clinic Payment Limits. I should have given this to you as a link, but let me just show it to you. I'm going to find the easiest way I know how to look it up. I'm going to give you a title. I'm going to tell you the easiest way I know how to look this up. Once you have the title, you can go through and try to dig it out. Great, great, great. Do that if you want. I don't like doing that. I instead will go to Google or any other search engine, and I'm going to put my title right here. What that's going to do for me is say, oh, okay, what do we got going on? Well, here it is. Here's our document. The reason that I like this document and laying it out is I think it's the easiest place you can come through and just scroll through. You could also search MM12185. You can put this on the CMS website, whatever you want to do. I just like it because when you go scroll down a little bit, it's going to have those rates lined right there. It's going to give you a lot of information. As I'm hitting the page, you can see right here in my rates to 2028. I think it's just the easiest place to find it. But this is what Congress has passed. Now keep in mind, this does not count those ones that are done under the 50 beds with the annual cost reports. Different set rates for every one of those. Okay. Now, with that said, I mentioned this a few different times. Yes, you have the all-inclusive rate for rural health clinic services, but you also have fee schedules that may apply, such as the physician fee schedule, a lab fee schedule, an ambulance fee schedule, and a durable medical equipment fee schedule. So depends on the fee schedules. How does the physician fee schedule apply? This is the one that applies when a service does not meet the rural health clinic criteria, but would still be a physician service. Rarely will this happen. However, this is the one that they use a lot of times to determine a patient deductible. This is why it's different than your all-inclusive rate. Hopefully that makes sense. They use the dollar amount on this fee schedule to set up your Part B deductible. Lab fee schedule. Most lab services under this fee schedule will not be part of your all-inclusive rate. One exception, the venipuncture, is part of the all-inclusive rate. It is considered a professional service. It is something that is done in a clinic. Therefore, it is part of your AIR. Ambulance, never going to be part of the AIR, and durable medical equipment, never going to be part of the AIR. If a service falls under either one of these, you do need to have a separate enrollment and bill these on the 1500 claim form. Same thing with the lab. All of these fall under the CMS 1500 claim form. It's a separate form with separate fee schedules. That's why you may need to do the 855B provider enrollment form to get any of these types of services billed. So you can see, just because you're a rural health clinic doesn't mean everything will automatically fall under your fee schedule. Keep in mind, hospice services are also not part of the rural health clinic. They are not medically reasonable and necessary. If you are certified as a hospice, you must do a separate enrollment form. Yes, you will bill on a UB04, but you will not bill us for hospice services. So keep all of those various pieces and components in mind when you're looking at that, okay? I've given you some different resources again throughout the slides. I'm not going to open up the general information for fee schedules, but remember all of these links are some of the different ones. Along with that, I decided that I would give you a list of resources. Now, these are some other things we haven't looked at, such as the Rural Health Clinic Center. It's just an area on the CMS website. It's going to try to combine everything that I just gave you, plus a whole lot more into one area. Really think it's good. I do like the Medicare Claims Processing Manual. Again, it's going to be a little different than the Benefit Policy Manual. If you remember, we looked at Chapter 13, but the Claims Processing Manual is instructions to us and to you to how we need to look at the claim, how you need to file the claim, and the information that needs to be on the claim. So it's different than the benefit manual. The benefit manual explains the benefits, explains what falls under a rural healthcare clinic, where the claims processing sections does it a little differently in that it tells what needs to be on the claim in order for those benefits to be paid or considered. Okay. Also, the Rural Health Clinic Preventive Services chart. I do like this. It'll talk to you about the preventative services that are part of or covered under a rural health clinic and the visits. I just think it's a great resource. All right, so giving you a lot of information, but let's get through some of these other questions that we still have remaining. What I'm going to ask you to do again is put questions that you have in the chat. We'll get through the questions that were pre-submitted, and then we'll see if we have any time for additional questions. So first, is it necessary to file claims to secondary payers after Medicare pays a rural health clinic claim? Also, is it necessary to file to primary payers when Medicare is paying for a rural health clinic claim? So let me answer a couple pieces. This has like 4 questions. So we'll answer the first one. Yes, you must file to secondary payers unless there's something going on with that secondary payer where they state it's not payable under a rural health clinic. Medicare does not determine what secondary payers you file, so you have to follow their guidelines. In terms of a primary payer before Medicare, absolutely. Just because you're a rural health clinic does not waive you from the Medicare secondary payer guidelines, which is when there is a primary payer before Medicare. You must follow all of the guidelines set within the internet-only manuals. So we have to make sure we're aware of that, just so you know. Does Medicare pay the full RHC rate? No, Medicare does not pay that. I explained that, and hopefully that made sense. What Medicare will do is look at it and pay that 80%, 20% after deductible. So for the most part, no, there's going to be an 80-20%. Someone asks, is there things that you can do to get a preventive care rate? And that's yes. And you got to make sure you append the appropriate information on the claim. The preventive care rate is the full primary care, or is the full Medicare allowed amount. So what do you need to do to file to a secondary insurance is the last portion of this question. And my answer to that is you need to contact that secondary insurance. They need to be able to instruct you what they need. It doesn't have anything to do with Medicare. Also, keep in mind an MA plan is not a primary or a secondary insurance. It is a replacement plan. We cannot talk about Medicare Advantage plans or MA plans. They're Part C and they're governed differently. Whether they have a portion similar to rural healthcare clinic is not up to us, to the plan, and how they choose to pay you or what they choose to pay is a little different. How they choose to pay you, the rates they pay are not necessarily the Medicare amounts. Now they must cover the basic and same services, but not at the same rate, not in the same way. You may even have to bill them differently. So where you bill your RHC service on a UB04, you may bill an Advantage plan on a 1500. I don't have a lot of information to give you other than that. How is the cost share determined in RHC? Okay, we've been a little bit around this one because remember I talked about like the physician fee schedule. The deductible would be based on the physician fee schedule, while the RHC is based on the air. So it's 2 different things, the all-inclusive rate. So the Medicare deductible and co-insurance do apply. The deductible is applied to the billed charge, not to the all-inclusive rate. The patient's responsibility and current insurance amount of 20% are applied after the deductible has been met. The RHC is paid at 80% of the air. It's important to note that 20% of the charges may not equal 20% of the all-inclusive rate if the charges are not equal to the all-inclusive rate. So again, we're looking at this very different amount going on, and that's where some of the confusion comes in. So you get a remittance notice and it doesn't show exactly what you were expecting to see there because the error isn't giving you a 20%. That's because there's a different amount going on. Let me give you an example. The total billed amount was $115. The error amount is $75. The patient deductible is $115. The beneficiary's responsibility will be $115. So we want to look at that and we say, okay, have they gotten that total amount? The provider may be reimbursed $40 in this case. Hopefully that all makes sense because that's the difference between what you billed and the error. So it's a formula. It's complex. It's not as easy and it's not as laid out as it is. So hopefully that made sense to you. Okay. Are there additional charges to RHC similar to FQHC? I kind of talked a little bit about this, but I wasn't really sure what you're talking about for additional charges. I'm guessing it's some of those things that aren't paid under the air, and the answer is absolutely there is. We've talked quite a bit about some of those different things and the fact that you do have to enroll separately for some of those different things to be paid. If that doesn't answer your questions, you may need to clarify what additional charges you're talking about. What is the difference between payment method 1 versus payment method 2, and why would a provider choose one over the other? Keep in mind, a rural health clinic does not have a method 1 and a method 2 payment. A critical access hospital has a method and 1 and 2 payment. These are separate designations and enrollments because a critical access hospital first and foremost is a hospital, while a rural health clinic is first and foremost a clinic and must perform outpatient clinical stuff, not outpatient hospital settings. Therefore, method 1 and method 2 would not apply to a rural health clinic. How to bill a rural health clinic claim? There's so many caveats and aspects to this because you want to make sure you have the right built up. You want to make sure you got the right revenue code. You want to make sure every single line has a procedure code. Every single line has to have a data service. These are outpatient claims. Outpatient claims are line item billed, and therefore each line must be done correctly. I'm not going to get into that. This is one where if you need more information, please put specifically what you're looking for. Please put specifically what you're looking for. So the next question, how behavioral health is integrated into an RHC. As I mentioned before, behavioral health or mental health is one of the professional areas that can be looked at as part of the RHC AIR. It is still part of the AIR, right? It's one payment. This doesn't mean you get separate payments for everything. Some of the behavioral health services will give you additional money depending on the type of service, and they're very specific. I didn't want to get into that billing in that type of class here. So if you want that designation, you're going to have to do that research on your own or ask specific questions for what you're looking for more than just a general is behavioral health part of the integrated RHC? Because the answer is yes, most behavioral health services will be billed. They will be part of the AIR and most will be paid as part of that all-inclusive rate. And then the next question was how many units of G0511 can be billed for a single data service? Are each paid at the error rate, or is it one flat error payment for the G0511, whether or not, depending on how many services are billed? Now remember, this is a transition care management service, and transition care management is part of a rural health clinic, so we're not looking at that differently. However, the payments for G0511 and 512 are not factored into the RHC error. CMS has made this an exception. They've stated this is an exception. They've given us a resource to do so. It's a questions and answers document. I do recommend you take a look at it. It's a great opportunity. I'm going to go ahead and just take a minute to put that into the chat while I keep talking here. Hopefully I can get the chat to open up while I'm doing this. Usually I let Leanne do all this stuff here. Okay, so looks like it went. So keep in mind, here's how this works. An RHC would be paid 80% of their rate for a billable service, subject to their RHC payment limitations, plus 80% of the charges for the care management service. Because this is an exception, it's a different set of payments. Now, the all-inclusive rate, remember, was for those medically necessary services. The transition care management is a little bit different in that it's trying to avoid medically necessary services in the future, and that's why it isn't part of the AIR, it's a separate payment. That's all explained within that FAQ, which I just put a link for in the chat. So with that said, that's the last question I have. Leanne, do we have any other questions?
We have one, Tom, and the question is, when is the AIR updated yearly?
Oh, so the AIR, okay, let me explain this. Let me try to explain this in an easier manner. The AIR is not updated yearly. What happens is the rate is updated yearly, but Congress doesn't pass a law that updates it yearly. Again, as I showed you in the document, and maybe I still have this up, I do. It actually, the laws that was set forward, and it says right here, gave us the years through 2028. So these will not be updated yearly. However, it does start at the beginning of each year. So does that make sense? Hopefully that makes sense. And then that goes through and it'll tell you right up here all the information you need. So right now it's set for an 8-year period. That 8-year period ends in 2028. This is under section 1832 of the Act, which is the Social Security Act. So hopefully that helps answer that question a little bit more there. Any other questions?
That is all of the questions.
Okay, so one final reminder. I am going to do 2 things with this. One, I'm going to make you get one of the big things, and I'm trying to get this to open. If you're not familiar with this area of our website, I want you to go to the training center. When you open the training center, the middle top box, if you have this set the same size I do, is Encores. Open it up. You're going to see this listed. View by date and title. Give me a couple of weeks. I can't just magically put this out there. It doesn't work that way. I would love to be able to do that. However, by the time we get it loaded and run it through, you'll see it there. If you want to find it earlier, you can do that, and I'll tell you how to do that in just a moment. Before I leave this page, I just want to remind you, I'm just going to use this transition care management one. There's a player where you can play it right here. This downloadable material will be the presentation. This is what's available for 60 to 90 days. This is where you can take the survey. Take the survey. Take the survey. Did I say that enough? Take the survey. Okay. But after that time frame is done, or you don't want to go to our website and you're more familiar with our YouTube channel, you can come out to youtube.com. I love their playlist. I think it's the best way to do it. Search for WPS GHA. You'll find our channel. Right. You can also use our handle at WPS GHA Education. Bring you right there. We'll let you know that I love playlists. This is how I do mine. If I come into my playlists, which isn't wanting to open right now, I'm going to look for one of 2 things: Rural Health Clinic playlist or Encore playlist. Be in both places. I don't always encourage people to look for the Encore playlist because it's huge. You can imagine we do a lot of education, and all of them are posted out here. So there's a variety of different. Rural Healthcare Clinic on the it'll bring up a couple of videos that we have, and then the playlist as well. So this is what you're looking for. And anything also applicable to it would be put within that Rural Healthcare Clinic. So just some different opportunities for you guys to do that. If the Rural Healthcare Clinic playlist doesn't open up, you can always just come back to playlist, leave the search field, look for it this way. It is right here, and this is where it will be. With that, I'd like to thank everybody for attending. Thanks for your time today. We do encourage you again, provide feedback on the survey. Please put the questions in there. Please put the information you're looking for. It will help me develop more in this series. Remember, I do want to hear the good, the bad, and the ugly though in that survey. Also, review our live events page for registrations coming up. Take the opportunity to check out the Encore presentations. With that said, on behalf of myself, Leanne, all the provider outreach and education, thanks for participating. We look forward to your survey comments, and we hope that you join us for future education. You may now disconnect.